have our Health for the World International Grand Round speaker today, Dr. Panagis Galiatsatos. Um, and Dr. Panagis completed his undergraduate studies at Temple University and his medical degree at the University of Maryland School of Medicine. He completed his residency at the Johns Hopkins Bayview Medical Center in internal medicine, and he served as an assistant chief of service. Then he went into pulmonary and critical care training at the NIH in Bethesda and at the Johns Hopkins in Baltimore. He also earned a master's in health sciences from Duke University and a master's as a tobacco treatment specialist from University of Pennsylvania. He's an assistant professor at the Johns Hopkins School of Medicine, where he currently co-directs Medicine for the Greater Good and is the community engagement co-director for the Baltimore Breast Center. Through his work in Baltimore City, he has been able to tackle community health needs through collaborations and partnerships, implementing population health strategies, and creating educational programs for healthcare professionals to become physician citizens. His projects have impacted over 7,000 Baltimore City persons and over 150 healthcare professional learners. Currently, his research interests are COPD, asthma, tobacco dependence, and health equity. He co authored a book, Building Health Community Partnerships Through Medical Religious Partnerships, that captures much of the projects he has implemented and overseen. He is the son of Greek immigrant parents and was born and raised in Baltimore. He has two children and is a wonderful person. I have known him for more than a year, and I've been always impressed by his good heart and also his vast fund of knowledge. So thank you so much for doing this for us, Panagis, and you can start whenever you're ready.
Of course. No, thank you so much. It's such an honor to be on. I remember that first conversation. I remember I was like pacing in front of the house with enthusiasm and just wondering how to be able to help you and your group and the mission that you have. And here we are a year later talking about the pandemic. Thank you all. Hoping what I'm going to try to do is keep this under 30 minutes because I really do want to allow for as much Q&A as possible. I think during this time, like listening to others who have managed COVID-19 is important because there is a lot of lessons to learn. I can tell you the doctor I was in the spring of 2020 is much different than the doctor I am now in the fall, almost winter of 2020, in regards to managing these COVID-19 patients. There's a lot that we've learned, a lot that I'll share clinically. And the other thing is as well is you guys, I'll make sure that you can have access to all of these slides. You can email me, consider me a colleague that can help you guys in any way, shape, or form. At the end of this, I'm also happy to discuss some international COVID-19 projects that we're doing for communities as well, if you're interested. So without further ado, I decided to title this COVID-19 lecture as Infinite Possibilities with Finite Interventions, because to date for this virus, we don't have a cure. We don't have a silver bullet to kind of knock it out. So what we have is, over 60 years of critical care training and using these same tools in different ways over and over again to help our patients who are struggling with COVID-19. So we're going to go over that. We're going to go over the supportive therapy, supportive interventions to some of the pharmacological interventions that either have been repurposed or have been kind of emphasized to use for the management of COVID-19. So we'll go over that. Then we're going to go into a few other objectives as well that I want to bring forth. So you'll see that I'm going to discuss, yes, we'll go over the COVID-19 interventions, but also I want you guys to understand that COVID-19 is not especially the immunometabolic phenotype that COVID-19 has. We've always suspected this is something very different than we've seen with other really bad diseases, right? If you have patients with community-acquired pneumonia who have to succumb to mechanical ventilation, yeah, those are bad patients. We know they get an immune response that's rather aggressive. But is that generic immune response to stress of an infection similar to what we're seeing with COVID-19, or is there something more unique with COVID-19? And then finally, I like to emphasize this, to understand the health disparities of COVID-19. And I say this because I always get asked the question, what can I do to prevent COVID-19, right? So catching the virus is SARS-CoV-2. If you have the virus and you develop symptoms, that's COVID-19. So how do you reduce the chances of developing COVID-19, or at least reduce your chances of developing severe COVID-19? And I always tell patients, it's what you do before catching a virus. If you don't have any pre-existing conditions, then great, maintain that healthy lifestyle that keeps you from catching or from developing non-communicable diseases like diabetes or hypertension. Or if you should have these pre-existing conditions that have been linked in countless studies to be associated with worse COVID-19 outcomes, then definitely touch base now with your healthcare professionals to better manage them. In some of the data out of Hopkins, we have been able to tease out that those with diabetes that is not well controlled do much worse than those with diabetes who have it under control. Actually, those patients seem to be on par with a general population. So the way I answer that is, it reminds me of one of my gynecological professors, where he's like, do you know what you tell patients how to have a healthy pregnancy is be healthy before the pregnancy, right? Because whenever your body goes through a stress, right, it's almost like a building with an earthquake. If the building is unsound, that earthquake will cause it to fall. If the building is sound, then the earthquake, nothing will happen. Same thing, if your body is sound, when an infection comes, you'll be able to launch an immune response that's appropriate and won't put you in harm's way. So anyway, going back to what we can do in critical care, another part is more of a holistic conversation of medicine overall. So this is the virus. This is what has caused us so much grievance over the last, since March 11th, when the World Health Organization declared a pandemic, SARS-CoV-2. A couple of things that I want to take a pause is quickly to recap coronaviruses, right? A quick time travel, right? If you all went to medical schools in the 80s or 90s, I'm not sure how much coronavirus conversations came up. I went to med school in the mid 2000s. I can tell you coronaviruses, there was a brief lecture mainly about SARS-CoV, and that was it. Right? Coronaviruses always potentially had the potential to be lethal, but for the most part, we recognize that the majority of coronaviruses just cause things analogous to the common cold. Not life-threatening, a little bit of life inconvenience, but that's about it. 2003 changed that. We had SARS-CoV, severe acute respiratory syndrome coronavirus. That did have a significant mortality rate in the regions of the world that it impacted through an epidemic. 10 years later, we had MERS-CoV, Middle Eastern Respiratory Syndrome coronavirus. Same concept. We had a coronavirus with lethality and able to spread. Key differences there, though, the majority of the spread did occur while patients were symptomatic. But I want to say this because both of those viruses, their spread and ultimately global impact was mitigated and stopped with just public health interventions. No vaccine, no cure. And so with SARS-CoV-2, until we can grasp great homogeneous public health interventions globally, where every part of the world is acting in accordance to stop the spread of this virus, we're going to have to rely on critical care to be ready to allocate the resources that we have, even though they are finite resources. So let's go over this. Let's go ahead and go over COVID-19 management for you all managing these patients with moderate COVID-19 to severe COVID-19. I say this because the way we differentiate this, and I know it's just kind of a stickler of nomenclature, is mild cases of COVID-19 are usually here in the United States just managed at home. These are patients that don't feel well, right? They have their fevers, they have their cough, their shortness of breath, but they don't have anything life-threatening, and there's not much supportive therapy that we can offer. So from that standpoint, they're usually managed at home. For moderate to severe cases, they do end up in American hospitals, and the severe cases definitely end up in our intensive care units. So let's go over exactly what we need to do to help combat this. So first of all, we are really going to explore supportive therapy. And by the way, the link to reference, I want to make this as easy as possible for you all to take this away. The best link that I would recommend is the NIH's Critical Care Medicine Guidelines. These get updated every 2 weeks. The people who put them together are colleagues that I knew during my training at the National Institutes of Health. Actually, just kind of a quick celebrity gloating. I worked with Dr. Fauci. During 2016, when we had Ebola patients in Bethesda of the NIH, we worked together side by side, caring for these patients. We had very difficult conversations of how to manage these patients that never had to come to fruition, but we take this seriously at the NIH and at Johns Hopkins and of course other places. But we want to not just help the patients, but we want to protect those who are helping the patients. You got to keep in mind, machines, medications, yes, there's a limited supply. There's also a limited supply of human beings who can deliver this work. So keeping you all safe should be a priority. So a couple of things from an infectious control. This is to help assure the healthcare professionals caring for these patients don't become infected. So the first thing I want to emphasize is the use of, from a personal protective equipment, PPE, is the respirator mask, right? These are analogous to the N95s, right? You want to use masks that are protecting the wearer. Typical surgical masks that are emphasized for lay persons to wear, that protects the spread of the infection from the wearer, doesn't protect the actual wearer. Your respirator masks protect you. I can tell you my intensive care unit, I typically wear the N95 when I'm in the hallways of the intensive care unit. I then, if I go into a patient's room, I'll still probably wear it along with a face shield. But if I'm going to be doing intubation, for instance, I usually put on my PAPR at that moment, PAPR. So if you have access to that, that's great. It's a hood with a vacuum in order to kind of create negative pressure ventilation inside your actual hood. But if you don't, still an N95 with a face shield is incredibly reasonable. The other thing you can consider doing is putting on an extra surgical mask over the N95. That way, if anything lands on your face, and goes through or manages to get through the face shield, it can land on that surgical mask to begin with. But protecting yourselves needs to be the priority because you are a limited resource. There's not many of you that can do this interventions or these jobs. So you must make sure that you protect yourself. Next, the other conversation is protecting other patients in the hospital. If you have the ability to convert rooms into negative pressure rooms, that would be ideal. That allows the ability for those rooms to remove the virus in real time and put it out into the air where it's not going from room to room inside of kind of a closed unit or closed ventilation space of a hospital. And finally, air management. I brought this up a little bit earlier, but majority of severe COVID-19 cases end up in rather severe pathologies such as ARDS, acute respiratory distress syndrome, or sepsis. Both of those conditions oftentimes result in the need to be put on breathing machines, specifically ventilators, so invasive ventilators. So if someone needs to be intubating a patient, please make sure you grab your most experienced individuals to do this. The reason why we emphasize this is, having all that equipment on to protect yourself, right, from N95s to surgical masks to face shield, it sometimes becomes cumbersome for a lot of our earlier trainees, and I've seen this happen in real time. What we do recommend is if you can use a video laryngoscope, it's ideal. Honestly, that's what the NIH recommends. From my standpoint, I recommend whatever you're most comfortable with. I still continue using my Miller blade in order to do my intubations, even for those with COVID-19. That's what I've been trained on, and I can get it done in a much more sufficient time frame. So airway management, that is the part that is going to be really the biggest spreader of the virus. The patient's mouth is wide open, right? You're bagging them, you're creating all these aerosols. So the reason why we put this under infectious control is because you want to minimize the time that patient is spent dropping these aerosols out in real time. So having your most experienced person, the reason why we emphasize that is it likely is associated with a shorter time frame of the patient generating tons of aerosol. Next, let's go to hemodynamic support. And I will say, keep in mind, this virus is less than a year old in human knowledge, right? So a lot of this information does get extrapolated from certain pathological syndromes that it can cause. For instance, sepsis or ARDS. So this hemodynamic support definitely comes a little bit from the sepsis literature as we extrapolate here. So what is a great mean arterial pressure to aim for? This is more from the sepsis literature, but keeping someone 60 to 65 millimeters of mercury or greater. Shock management, vasopressor of choice always seems to default to norepinephrine. My clinical experience, it's been great. I usually will add vasopressin to this as well if I'm increasing the amount of norepinephrine that I'm using. So you can always add a second line vasopressor. Vasopressin specifically is ideal. It helps kind of mitigate the amount of norepinephrine that you ultimately use, just because higher doses of norepinephrine do carry their own side effects. With that said, the next one is one that I always would like to emphasize, right? Our stress response to a stressor is controlled through a variety of hormones, adrenaline being one of them, case in point norepinephrine, and your cortisol, right, your stress hormone. And the ability to mount an appropriate stress response, your adrenal glands really have to mount it aggressively. And so if you're finding patients who are in refractory shock, right? You're adding a second pressor. You've given them fluids. You think they're well hydrated. Please strongly consider hydrocortisone at this moment, right? I've seen countless patients turn around quickly from a pressor standpoint the second we begin to add hydrocortisone. Now you may say, well, hold on, Panagis, aren't you going to talk about steroids in a second with dexamethasone? I am. So quick physiology recap. Keep in mind, not all steroids are the same. Some of them are glucocorticoid predominant and others are mineralocorticoid predominant. Mineralocorticoid are the steroids that have an impact on blood pressure. Glucocorticoids mainly have an impact more ways, but mainly on the immune response. Dexamethasone has almost no mineralocorticoid activity. So when my patients come into the hospital, and you'll see this when we cover the dexamethasone conversation in a little bit, yeah, I have patients on both hydrocortisone and dexamethasone at the same time. We do this often. It seems to be beneficial for the patients. If your patient needs prednisone for whatever reason, whether they have an asthma exacerbation along with COVID-19, I encourage you to have that individualized conversation, but dexamethasone should be enough glucocorticoid response to help minimize that inflammation. And we'll go over that, by the way, a little bit later on. But this recap is to assure you that you can use these two steroids at once, the hydrocortisone and the dexamethasone, because they're acting on two different response systems. One on the cacophony of the immune system, we'll go over that in a second, and the other one on the hemodynamic support with adding a mineralocorticoid. Now the ventilatory support, non-invasive. So obviously if your patients need oxygen, give them oxygen. But whenever we provide ventilatory support, there's really two things that we're looking to try to help with. One is work of breathing. So if your patient really seems to be struggling, I would at that moment begin to transition from nasal cannula to something to help them with this. And I understand these might be of limited resource, but I still just emphasize them. Your non-invasive positive pressure ventilations, these are your CPAPs or BiPAPs, or your high flow nasal cannula. They all provide oxygen, yes, but they're providing an ability to help with the work of breathing of a patient. That's important because if the patient's work of breathing is excessive, they will fatigue, they will transition into respiratory failure, or you'll have to intubate them. So which modality of non-invasive ventilatory support do we want to emphasize? The big one is high flow nasal cannula. And a lot of it has, there's a variety of reasons. Keep in mind, I do want to emphasize that high flow nasal cannula does generate a lot of aerosol. So if someone has it on, we would always encourage the patients to continue wearing their own face masks. The reason why we're going to make this emphasis is because with BiPAP and CPAP, it's usually a full facial covering, and patients may be on this for quite some time, right? So that means if they're on there for quite some time, they're not eating, they're not doing a variety of things. And so and they're usually uncomfortable in taking this mask off a lot. So their compliance with this intervention seems to fall down. So high flow nasal cannula does get emphasized to be one of the first lines that we want to use. However, if you don't have access to that, non-invasive positive pressure ventilation is perfectly fine to use. Again, you're using this to help with work of breathing in addition to oxygenation. We oftentimes see patients with rather profound hypoxemia, and they're comfortable. They're oftentimes just sitting with their cell phone talking to us. In that case, you can definitely go from nasal cannula to non-rebreathers, but keep in mind, non-rebreathers generate a lot of aerosol. So if that seems to be the case, you really have to keep these patients in a room isolated from others, ideally in a negative pressure room, so they are not spreading this virus to other people. And keep in mind with the staff, whenever they go in, they have to remove those boundary clothings that they're wearing and throw them out. So if you're going to use a non-rebreather, it generates a lot of aerosol, so please keep that in mind. So back to these patients in regards to other things you can do. The awake prone trials seem to buy us time, yes. So these are patients who are cognitive, they can listen, and they can lay on their chest for periods of time and then lay on their backs. Of course, this just causes kind of a shunting of blood circulation as parts of the lungs do expand and open, allowing some of those lungs that have reopened, that potentially are healthy, to acquire more blood and so forth, better oxygenate these patients. In my experience, this tends to stave off intubation. Yes, But you want to keep a close eye on these patients. If you are at the moment, when you're implementing high flow nasal cannula or BiPAP, and you are doing awake prone trials, you want to keep a close eye on these patients. These are the patients that 2 to 3 days later get worse. From my clinical experience with these patients is that the way they come into the emergency room to progression of severe COVID-19 being admitted to my intensive care unit can take time, can take a period of over a week. I have, in all the patients we have admitted to the intensive care unit, less than 5% come straight from the emergency room. 95% of them go from the emergency room to the general medical floor, and then from there to us. Not because the medical floor did anything wrong, it's just that this disease gradually continues to progress, and the compensations that the patients have for themselves ultimately is lost. So you want to keep a close eye on these patients if you're already implementing non-invasive ventilation strategies and having to do awake prone trials. Yes, you're losing, you got to recognize your patients are about to plateau where they either will turn around or they'll get worse. Again, I think it goes without saying, you want to have these patients in close monitoring with experienced practitioners. When I say experienced practitioners, it doesn't have to be COVID-19 experience. We weren't when we started taking care of them in the spring. It just means people who manage critically ill patients often. You know, for those critical care doctors that are listening to this message, and really all other physicians to some extent, yes. But you know, one of the skills that you have sharpened over time is how to kind of differentiate a patient going south, a patient getting worse versus a patient who was not. So please keep that in mind. If you have, your hospital has access to physicians who oftentimes deal with patients in life-threatening conditions, have them try to at least provide some input of where their conditions are. If they're doing okay, they can maintain on the floor, or yeah, they might be getting worse. Now, if you do have to intubate these patients, you know, our strategies here are no different than any other disease of respiratory failure. You want to focus on lung protective ventilation. So that usually means, you know, for adults. By the way, all of this conversation is really meant for the adults. I'm a physician who cares only for adult patients. My experience with pediatrics is very limited. So if you have pediatric specific questions, I'm happy to attempt to answer them, but I'm going to default and say, well, let's grab you a pediatrician to help. But for lung protective strategies in adults, we usually do this with volume cycled. So we have a fixed tidal volume that we deliver to the patients. So when you do that for these patients, you do continue using lung protective ventilation. You know, even if they develop into severe ARDS, these are 3 key variables that I always use to help guide me. Monitoring, so giving some level of PEEP, usually a 5 or more, so that positive end expiratory pressure. So 5 or more should be just enough. Obviously, you can continue going higher if you need to help improve oxygenation where your FiO2 is almost maxed out. Next, low tidal volumes. Low tidal volume is the reason why we're emphasizing that is because we're trying to keep patients under what we call the upper inflection point, right? Ventilating above that usually results in barotrauma. Low tidal volumes usually should keep our patients well under that upper inflection point. And if you're wondering, Panagis, how do I find the upper inflection point? You can do that, or you can default to the decades of literature from ARDS where we use the plateau pressure of about 30 to say that should be good enough, right? Our ARDS studies really emphasize breathing above 30, more likely to have barotrauma and volutrauma. Having plateau pressures below 30, you usually can be okay. So plateau pressure of 30 is what I continue emphasizing. And, you know, using your PEEP and FiO2 to help with oxygenation, you know, if you go up on PEEP, you really want to continue monitoring your plateau pressures. You don't want to be the reason why you drive someone into barotrauma by doing too much with the PEEP. I will tell you this, from my experience, these patients, if they're intubated, take time to heal. So it is not uncommon if you walk into the patient's room and the only thing you do is go from 90% oxygen to 80%, and that's it. That's it. Don't try to do too much. Maybe you'll prone them during that day or maybe not. Proning, the last thing I want to emphasize about proning for patients who are not awake, this is for patients who are intubated. You want to do it if you know what you're doing. So what I'm trying to say here is at Hopkins, we put together a prone team because there are certain intensive care units that were not used to proning patients who are intubated. And that's really important because if you try to flip a patient with that breathing tube in them, and practitioners who are not experienced with doing that, you could dislodge the breathing tube. You can pull out catheters that are in them. So I say this, interventions are only as good as the people who know how to use them. So if your hospital doesn't have people who know how to prone, don't try to prone in real time, right? Leave that off as one of the strategies. And you can rely on just PEEP and monitoring plateau pressures to help. If you have a prone team, great. If you have practitioners who are experienced with that, fine. You can use this. And what I would recommend is usually the first 72 hours, proning every 12 hours. After that, the efficacy of proning, in my experience, usually gets lost. And the side effects of proning usually begin to rise. There are side effects and consequences of proning. So lung protective ventilation hasn't changed, but I want to caution you guys, it takes time for patients, right? You have to recognize that once they get intubated, they're not going to turn around quickly. So don't feel like you need to do something more with the ventilator. Sometimes just one tweak is good enough. In regards to ECMO, I'm not sure how much of a resource that is available to you all. And this is the extracorporeal membrane oxygenation. It is a limited resource, even in the United States. We have limited data to really emphasize it. I will say the few patients who have gotten ECMO, these tend to be young with no pre-existing conditions. They usually were on it for about 3 months. They did well. We have yet to have a fatality with ECMO. But again, we use patients who were healthy to begin with. Their biggest downfall is having COVID-19. So it is not a resource that we go to frequently, but for the few cases we have here at Hopkins, we've seen a turnaround. I think that's kind of the overall status of ECMO in the United States. We do see benefit, but again, keep in mind, we usually place patients who themselves are young, no pre-existing conditions, and we do think they'll have a big turnaround. Next, acute kidney injury tends to happen pretty frequently in the intensive care units overall. And in COVID-19, we do see kind of a high uptake of it. Now, is it related to COVID-19 because of its ability to bind to the ACE2 receptors of the kidneys and cause damage? Or is it just due to shock, due to the medications we give and so forth? Hard to tease out. But I will say that if your patients do need renal replacement therapy, by all means, try to use continuous renal replacement therapy, either using CVVH or CVHD, depending on the modality you're comfortable with. If you don't have access to that, definitely talk with your nephrology team, or maybe you oversee it. You can still use intermittent hemodialysis, but I will run it at much lower blood flow rates and ultrafiltration rates in order to not have massive swings of hemodynamics. So AKI, keep in mind, it's probably our second most common intervention that we need to do with patients with COVID-19. It's pretty frequent in our patient population, anywhere from 15 to 20%. Now, finally, let's go over medications. Again, we don't have cures. We have interventions that are meant to kind of mitigate the severity of COVID-19. When COVID-19 broke out into the world stage, tons of medications were brought forward to be candidates. And a lot of these medications were either repurposed, like hydroxychloroquine, or made, or tocilizumab, or meant to be new, just specifically for SARS-CoV-2, for instance, with remdesivir. Now, a lot of drug trials have happened over this time. Keep in mind, a lot of these medications, the reason why they were emphasized to begin with is because they showed in vitro benefit in a lab. Well, labs are great, gets us to generate hypotheses, but real life clinical management is much different. And that's where we're looking to see, does it work in real time? And so who, over now 8 months, who has remained kind of there for severe COVID-19 management? It's 2 medications. So let's go over them. First is remdesivir. Remdesivir got a lot of notoriety with some coronaviruses back in the early 2010s, and then with Ebola in mid-2016. It inhibits RNA polymerase. In vitro studies showed it great, as I said, with earlier coronaviruses. So why not see if this medication could be good for SARS-CoV-2? And in my clinical experience, it's often hard to say if it made an impact. I'll be blunt. Did it shorten their time of being sick? Maybe. Those are always things that are hard to kind of really identify. Did it save people's lives? In my clinical experience, it didn't feel like it did, because we were definitely using a lot of remdesivir in the spring of 2020. And sure enough, even the trials that came up with this, the biggest thing that they see in remdesivir is the ability to mitigate the time spent ill with COVID-19. And so look at remdesivir versus a placebo in this large New England Journal of Medicine study with over 1,000 patients recruited, 10 days to 15 days. Again, that's great. It gets people to potentially turn around sooner. But if you have access to remdesivir, great. If you don't, I don't think this is a holy grail overall. So I wouldn't strongly put a lot of emphasis of saying we need to get our hospital to have remdesivir. I mean this, shortening recovery time, I think is great. Don't get me wrong. It's important. But at the same time, I think, as you'll see with the dexamethasone study, I think that's more of a medication that I would turn to in severe COVID-19. So remdesivir, if your hospital can access it, I think it's reasonable. Keep in mind that what the outcome you're going to see is just a lesser amount of days spent ill. There isn't a mortality benefit at 28 days. Now, with this said, this is for dexamethasone, sorry. Going back to Act 1, the mortality benefit seen at 28 days with regards to remdesivir was not statistically significant. The models that we run and so forth. And I would say in my own clinical practice, it's hard for me to say patients were surviving better when we use remdesivir a lot more. I do feel like there's a bit of a shift with dexamethasone. I feel like clinically I'm seeing that, and I do feel like, the data that's been published helps support my clinical experience with this medication. So a couple of things I do want to emphasize about glucocorticoid steroids, right? When we use them to blunt the immune response, the immune system is fantastic, right? I give my hat off to the immune system where every day it's making decisions about friend or foe from every foreign substance it breathes in. When your immune system is working like a symphony, where everything is firing off organized and well, generates a little bit of fever to try to kill off this infection, you don't want to stop that. You don't want to impair that. So we have seen using steroids in patients with mild cases of COVID-19 can be detrimental, right? That makes sense. You don't want to stop an immune process that is working well. In patients with severe COVID-19, you do want to stop that immune response, because that immune response tends to be an over-exaggeration, no longer a symphony, and it's more of a cacophony. And we'll go over that in a little bit when we cover the immunometabolic profile of COVID-19. So dexamethasone in these trials, the biggest one published recently in New England Journal of Medicine a few weeks back, did show a mortality benefit at 28 days. And I will say in my clinical experience, I feel like I see the same thing, because we began to utilize dexamethasone predominantly in the spring and summer, around July, after the Lancet study came out. We say, all right, let's turn to it. Because prior to that, we weren't using steroids. Actually, we were staying away from steroids, seeing that they may have caused harm. And the harm that we saw was when you use steroids in mild cases. So in severe cases, there's likely going to be a benefit. So these are the two medications going into this now, remdesivir and dexamethasone. These are the drug dosing for both of them. What are the recommendations? So let's do a stepwise approach. If your patients are not hospitalized and not on supplemental oxygen, 100% do not touch them with steroids, right? That means they are fighting COVID-19 appropriately with your immune response. You don't want to stop that. Remdesivir can be considered. I can tell you the data to support that is not strong. So it can be a consideration in back of people's minds if they want to consider it. Now they're hospitalized and they require oxygen. These are patients where the NIH critical care guidelines are recommending remdesivir alone or remdesivir with dexamethasone. Now, on the general medical floors, I know they do this often. I know now they're utilizing remdesivir. And again, the hope is, can they minimize the amount of days these patients are spent sick? I will say, though, I don't know if it helps prevent them from ending up coming into my intensive care units. If you want to use dexamethasone in these patients, the evidence is reasonable to suggest that we have begun doing that more on the floors if we're finding patients that we are concerned about them going from moderate COVID-19 to severe. How do you identify that? Honestly, it's still more of a clinical gestalt, still kind of knowing the patients and seeing how their trajectory is going. If they've gone from 2 liters nasal cannula to 6 liters in a couple of days, those are the patients I'm adding dexamethasone to. If these are patients on 2 liters, but over 48 hours, their work of breathing seems to get worse, those are patients I'm adding steroids to. So remdesivir tends to be used a lot on our general medical floors with dexamethasone. Now they're hospitalized and they require non-invasive ventilation. Dexamethasone is your first line. You can definitely use it alone or in combination with remdesivir. Mechanical ventilation or ECMO, dexamethasone by far has the greatest data to support that. Dexamethasone remdesivir has a little bit of advocacy in the NIH, but it's dexamethasone, right? Here we are saying the proxy of the mechanical ventilation implies that the immune response is so chaotic, right? Because it's not the virus itself. It's the massive immunological response of pro-inflammation that we're seeing done by COVID-19 that results in massive capillary leaks from the lungs to the kidneys and so forth that gets these patients into dire consequence, right? We've seen this before. We know this. Sepsis does that. ARDS is similar, right? It's a capillary situation of endothelial dysfunction that results in massive leakage of fluid and so forth in a pro-inflammatory state that needs to be mitigated. So dexamethasone definitely for your patients who are requiring much more interventions from non-invasive to invasive ventilation. Now let's go over this a little bit, right? Let's do a little bit of science to back this up. Is there a distinct inflammatory profile of COVID-19 or is it just a generic response to severe illness? And I will see my colleagues in Ireland put out an amazing study several days ago that allows me to publicly announce this. Otherwise, I was going to just tell you guys, hey, keep it under wraps until this publication comes out. But we do know COVID-19 launches pro-inflammatory markers, IL-1 beta, IL-6, and TNF-alpha, all of them generated by neutrophils. This isn't unique to COVID-19. Bacteria causing community-acquired pneumonia can cause these elevations too. But what's interesting from this study out of Ireland is that the height of IL-1, interleukin-1 beta, interleukin-6, and TNF-alpha, the elevation, right, of COVID-19 intensive care unit patients is much greater than those with community-acquired pneumonia requiring mechanical ventilation, right? So the pro-inflammatory response seems to be much more heightened in COVID-19 severe cases versus a matched group of patients with community-acquired pneumonia who need mechanical ventilation. Second, this is what's fascinating too, right? We know hypoxemia is occurring with these patients and oftentimes in severe levels. This tends to activate the glycolysis pathway. So what we've seen in these COVID-19 patients with severe cases is that pyruvate kinase M2, right? PKM2. This is there's 2 pyruvate kinases, by the way. One that usually launches people into the Krebs cycle, if you remember your biochemistry, and another one that sticks with the glycolysis process. If you're in glycolysis, you're going to be activating a lot more of the hypoxic inducing factor 1 alpha. This is HIF1 alpha. This protein often transcribes these pro-inflammatory markers. So right off the bat, severe hypoxemia, this is why you want to mitigate this almost immediately when patients come in the emergency room with supplemental oxygen as they need. But you want to be cautious of this because the more times these patients spend in hypoxemia, the more likely they're going to transition into severe COVID-19 because of these markers that are becoming much more elevated. So COVID-19 patients see a higher amount of these 2 proteins and enzymes within the neutrophils of these patients with severe COVID-19. And finally, this is by far the most fascinating thing for me to have you guys walk away. There are anti-inflammatory responses to a severe disease, right? You want to create a yin and yang, a balance of a lot of pro-inflammation, but your body is trying to mitigate that, right? IL-10 gets released, alpha-1 antitrypsin gets released. By the way, alpha-1 antitrypsin gets activated whenever IL-6 gets released. So that makes sense, right? Your body produces a pro-inflammatory marker and at the same time activates an anti-inflammatory marker to kind of keep things in balance. But this is what is so fascinating about COVID-19 is that the IL-10 response and alpha-1 antitrypsin response is not heightened to the level of the pro-inflammatory responses. So what we see in these patients with severe COVID-19 is a pro-inflammatory response that is so high, there's not an appropriate compensation for the anti-inflammatory response. Anti-inflammatory markers are getting released, but nowhere near at the level they need to be to mitigate the pro-inflammation. And this is why things like steroids, dexamethasone with glucocorticoid capabilities is so important to help these patients overcome that pro-inflammatory state that we're seeing, that cacophony. So the conclusion from these scientists, as well as others who have been evaluating this, there is an immunometabolic reprogramming in patients with severe COVID-19, meaning there is a specific immunological and metabolic phenotype to severe COVID-19. That's predominant glycolysis with HIF-1 alpha in the neutrophils activating massive pro-inflammatory interleukins and TNF alpha. So 1 beta, 6, and TNF alpha without at all an appropriate compensation with anti-inflammatory markers. Now, I bring all this up because this happens in sepsis. We know this, IL-1 beta, TNF alpha, IL-6. I throw in ILA. ILA is also elevated in COVID-19, but it's matched with CAP of patients with community-acquired pneumonia being intubated. So they're both elevated, but you can differentiate COVID-19 versus community-acquired pneumonia with between the two. But I do want to bring up another thing. Those same markers are elevated ever so slightly in patients with hypertension and type 2 diabetes. And I say this because those are two patients pre-COVID that had a lot more chances, or that you would see run in a clustering with patients with more sepsis. So if you look at all the sepsis data pre-COVID-19, patients who develop sepsis, what do they tend to be? Those patients tend to have diabetes and high blood pressure. We've known this. Now with COVID-19, those are the same patient populations that have worse outcomes. So this is why I made the point for your community, if you're willing to help them with sepsis, yes, COVID-19, yes, face mask, physical distancing, hand hygiene, I would never say no to that. But now more than ever is a moment to make sure these non-communicable diseases of diabetes and hypertension are cared for as best as they can be. And I say this because here in the United States, minorities tend to have a lot more of poorly controlled or not well controlled diabetes or hypertension, and these seem to be the same populations that are suffering disproportionately from COVID-19. So that is the end of our lecture. I'm hoping you guys recognize where we're at with clinical management. I know I went through a variety of key evidence-based interventions, but the one part that I can tell you clinically I want you all to walk away with is be patient. These patients do not turn around quickly, even with your dexamethasone, even with your remdesivir, they take time. On average, our intensive care unit patients stay for about 21 days, 3 weeks. That's a long time in a modern intensive care unit in an industrialized nation. That's a long time. So be patient with these patients. They don't turn around quickly. Every day you might do 1 or 2 things. The last part, by the way, and I apologize, it slipped my mind, I meant to say this out loud. There is a role for antibiotics if you think there is a superimposed infection. Oftentimes, I leave it up to the physician to make that remark. If you feel like, hey, that CAT scan is more consolidation and ground glass opacifications, that might be reasonable enough to pull an antibiotic to say maybe there's a superimposed infection. We do a lot of daily blood cultures on these patients when we start dexamethasone. Why? Dexamethasone is a glucocorticoid. It is a great mitigator of fevers. So these patients, their fevers, you may say, oh, their fevers are gone. It's oftentimes to the medication. So we do daily blood cultures and culturing any sputum that they might come out just because we're concerned about that. Last thing I would mention as well is that pro-inflammatory state that you saw, high inflammation. Guess what that also leads to? High burden of clots, right? The amount of catheters that we used to change because it will get clotted off, the amount of new deep venous thromboembolisms or PEs we discovered. I had a patient, our last time, tons of PEs throughout the lungs, young patient. I say this because we do emphasize that for DVT management, it is no longer just prophylaxis dosing, it is therapeutic dosing. So put these patients on enoxaparin that is appropriate if they had a clot. Treat these patients who come in with severe COVID-19 immediately as if they have clots, because I promise you they will develop, and a lot of your interventions of catheters and so forth will be lost. So antibiotics and therapeutic anticoagulation to be added as well, in addition to the other parts that I mentioned. So let me stop here. I said 10:30. I apologize. I'm a little over. Get a little excited when I have these conversations. So happy to take questions.
Thank you so much. That was an excellent talk. And, I think our audience found this really very helpful, especially given the times in which we are going through this. So we have some questions here, Panagis. I'm going to read this out from the Q&A box. The first one is the management of hypertensive and diabetic patients for COVID-19.
So the management the question was the management for hypotension or hypertension?
Hypertension. Yeah.
So if this is meant from an outpatient strategy, the American Heart Association here, has made it clear, like, control your patient's blood pressure with evidence-based guidelines that they've recommended. So I know angiotensin converting enzymes inhibitor medications they're like, hey, our ACE inhibitors are appropriate to use in this time? Will they cause any issues with the ACE2 receptor? Honestly, what the American Heart Association continues to emphasize is treat your patients with evidence-based antihypertensives that is appropriate for the patient, right? So I think ACE inhibitors and beta blockers are still emphasized for those with cardiac disease. Obviously, if they don't seem to work or they have side effects, and then continue going to the next tier of medications. But what I would follow along is the American Heart Association's emphasis on which evidence-based medications to use. And oftentimes it has to do with what clinical comorbidities your patients also have. Like if they have high blood pressure and diabetes, use ACE inhibitors. To date, we haven't seen any issues with ACE inhibitors and COVID-19 severity and so forth.
Okay, that's great. There's a question from Grace Jackson. What can you say about the vaccines being produced? Do you see a large impact in the decrease of COVID-19 cases after the vaccines?
So the vaccine is, so I'm one of the co-investigators for the AstraZeneca Oxford vaccine. To date, that data we're still not dispensing, we're holding onto it at the moment. So probably around December, we can make the 3-month phase 3 trials for these a little bit more public. But it's hard to say. I say this because your phase 1 and phase 2, we used healthy individuals who otherwise, probably wouldn't have gotten COVID-19 based on kind of their just overall, social encounters and so forth. Phase 3 trials where you're really recruiting right now vulnerable populations, patients in nursing homes, minorities, and so forth. These are patients that we see a disproportionate impact of COVID-19. So around December to January, we can give you a little bit more insight into what we're seeing from the vaccine. I will say the herd immunity overall to capture can come from a vaccine, right? We calculate the reproduction number constantly to see where we need to be. We need to be somewhere around 70, 80% of people with immunity to overall give us a kind of a sense of herd immunity. But herd immunity to happen naturally, this is a fear that we have because, I say this because I'm not sure if you guys have recognized, there have been 4 documented cases of reinfections. When I say reinfections, I mean people who were tested with $1 million laboratory testings to run their COVID-19 against genetic profiling, right? So these were patients who, yes, were declared to have 2 unique strains based off genetic profiling. And these are often young patients who then got reinfected months later and developed 2 out of the 4 cases developed severe COVID-19. So I really want to make this point, the vaccine information for phase 3 will probably come out for, at least from AstraZeneca's standpoint, around December, early January to see how we're doing. But you really want that 6-month benchmark because you want an immune response. Every vaccine needs to strive for an immune response for 6 months. That's what the flu vaccine strives for instance, around these kind of viruses, zoonotic viruses. So back to the reinfection concern, this is why if we're going to achieve herd immunity, we're going to achieve it on the backs of science. We're going to achieve it on the backs of a vaccine because Mother Nature is highly clever, and the fact that you can already see reinfections happening in patients with milder cases should concern every healthcare professional and every public health official, because we need to make those emphasis of face masking, physical distancing, and hand hygiene ever so more of an emphasis now.
Yeah, I think that makes a lot of sense. And I think what Dr. Panagis is saying is extremely useful. Once a vaccine comes out, it doesn't mean you have to stop the masks and the social distancing. All those measures should go on. We have a question from Cameroon. Let me just unmute. Otherwise, I think they are typing in the chat box. And Mike, maybe you can try to unmute them. They said, what form of treatment is considered for patients who are not hospitalized and are not on supplemental oxygen? If remdesivir is
For patients who are not hospitalized and not on supplemental oxygen, I know, let me put this, let me say this. I know as physicians and our nursing colleagues, like we all want to do something to make a difference, to cure a patient, to help. COVID-19 has rocked us because we didn't have cures, we still don't have cures, right? And so being patient and really just relying on the patient's body to do the job of an immune system, that's all we can do. We can sit back and just close the monitor. And so when I give these talks to primary care physicians or other doctors who are managing patients in the outpatient setting, they want a quick fix. They want, hey, can I give them hydroxychloroquine? Can I give them azithromycin? Give them something. And I tell them, no, we haven't seen any single benefit of any of these interventions. If they have comorbidities that warrant it, sure. If they have COPD and they're going through an exacerbation because of COVID-19, yeah, give them steroids, give them, azithromycin. That's fine. You're treating the morbidity. But for patients who are at home and managing this, and they don't need oxygen, what I would strongly encourage, make sure they stay well hydrated, stay well fed. I know that sounds overly simple, but they are using an immune system that is appropriate at that moment. And you don't want to do anything to de-escalate that. So that's we don't have any medications through trials that have shown to be advantageous in the outpatient setting at the moment.
And I think, Panagis, you already answered this question. This is another question from Cameroon. Given that remdesivir is not widely available, do you think it's premature to conclude that HCQ is ineffective? In Cameroon, we have treated patients only with HCQ, and they have been declared cured in several treatment centers in the country. Do we need more studies specifically in the low and middle income countries before ruling out HCQ?
Yeah, so I will always say this, the bias that we have as physicians and scientists, well, not bias. All right, let's talk about, we rely on three things, right? Whenever you guys make a clinical decision, usually you're trying to pull from three experiences: the biological plausibility, your own clinical experience, and evidence-based medicine. In a pandemic, in a virus that is new to us, it's not even a year old, we're going to rely a little bit on biological plausibility. Hydroxychloroquine had that, right? We saw that back in 2006. It had in vitro capabilities on coronaviruses. Then you're going to rely on clinical experience. The challenge that I have with clinical experience is it always is going to be biased, right? That's why we rely on evidence-based interventions where bias is mitigated, it's removed, and we're just going to let the objectives come about. And so I can tell you, I prescribed hydroxychloroquine back in March, and I felt like it worked for patients. But the other part of that is that just survival bias, right? Would that have just worked for patients if we did nothing? And so moving forward, I have as many patients, if not more, managed in the outpatient setting where I didn't do anything. I'd say, stay home, hydrate, be fine. Days later, hey doc, feel better. Symptoms are gone. So I know it's that human nature of physicians and nurses and so forth. We want to do something, but I feel like I can match every case of someone who's given hydroxychloroquine to cases where I haven't given anything, and they did fine. So what I would strongly recommend is I really would rely a little bit more on the evidence, because it removes the bias that we may have had clinically, right? Because whatever you did and you feel like you got a result, you're like, is that cause and effect or just survival bias that's happening now? That's why we rely on unbiased studies. From my perspective, the studies that have come out, recognizing, reviewing their methodologies, those are unbiased. I put a lot of thought into them. I spoke with a French doctor who put out that hydroxychloroquine study back in March, and he made it clear, it's like, that study was meant to generate hypotheses. It was never a cause and effect, right? The trial was not designed like that. So we need to be cautious about that, especially for our patients, where we don't want to give them the impression that, we're trying to cure, or we don't have that capability at the moment. So,
Right.
Take that into consideration. From my standpoint, I don't offer HCQ, hydroxychloroquine. I'm reserved from that, and I have plenty of patients who have done well in the outpatient world with just close observation with our nurse, hydrated and monitoring vital signs.
Right. We have Dr. Shrestha from Nepal who had a question. Dr. Shrestha, please go ahead.
Thank you. Hello, Dr. Panagis. It was a wonderful presentation by you, covering all the elements of coronavirus and its treatment. and it's that this pandemic situation. We are also dealing with lots of patients in ICU, and to be precise, I will be asking few questions regarding ventilator of patient with ARDS with COVID-19. So we are really facing the problem of when to go invasive ventilation when patient is currently on non-invasive ventilation. So sometimes the clear-cut decision to take the patient into invasive, and sometimes very difficult to whether to go invasive or not. So what's your point on that? What are the criteria to we like to look after so that we go into invasive rather than sticking to the non-invasive, or shifting directly into invasive, not going into non-invasive?
No, and Rashad, that's a fantastic question. The challenge here is it's hard to come up with, you know, so, you know, in critical care, we always make a point, these are guidelines and not rules. You know, guidelines really are going to rely on you to make that clinical decision. And I say this a couple of things, right? I always like to point out your interventions are only as good as the people who can use them, right? If I gave you a, you know, $1 million new breathing machine and you've never been taught how to use it, you're like, I don't know how to use, or actually maybe a better analogy. If I gave you a Porsche and you don't know how to drive stick shift, what good is that Porsche to you, right? So what I say this to every practitioner is, if you feel confident with your patients being on non-invasive, and you have confidence that you have good, close supervision on these patients, you can wait. But if you're feeling like, hey, you know, I'm putting this on, but they're oxygen, like I can't even keep them above 90% with 100% non-invasiveness, their work of breathing, I'm giving you the most extreme because that usually, to me, triggers, let's go ahead and put them on intubation. But from that gray area of like when trigger, I would really, you know, oxygenation at its most extremes if you have to oxygenate. The other key part, Rashad, look at their work of breathing. If they feel comfortable and they're like, hey, I'm okay, like and this is more in America, you know, these patients are like on their cell phone on 100% from a high flow nasal cannula, and they're just sitting there on their cell phone. I don't intubate them. I ask them, the prone, hey, get on your chest a little bit. But usually what drives me to intubating is either work or breathing, where even if their oxygenation is not horrible, but if they just can't keep up with the metabolic response from their lungs, I may be driven there. Or refractory hypoxemia, not with non-invasive ventilation, and work of breathing that's rather excessive. If I can't do that, then I get forced to intubate. But Rashad, I mean, you're asking a great question. The challenge that we have is you do want to give them as much fighting chances to kind of overcome this on their own. But keep in mind, it's only as good as the comfort that you feel with yourself and your colleagues. If you have to intubate, I wouldn't delay it. You know that delaying intubation oftentimes results in worse outcomes than being a little bit more premature.
So I'd like to add another question right here. So what kind of people, or what level of people would you like to initially select the patient with severe ARDS?
So for me, initially, honestly, I like to put them on 5. Right off the bat, at that moment, I put them on 5 and I take a look at what their oxygenation level is. I try to use FiO, so put them on 5, put them on tidal volume, and then calculate my initial plateau pressure, right? If it's 20, then I know I got time to tinker with the PEEP a little bit more, as opposed to going up on FiO2. So I intubate, I put them on low tidal volume, I set them at 5, calculate a plateau pressure on that. Then I begin to increase a little bit of the PEEP in order to match the oxygenation I want. I try to avoid too much oxygen if I can, try to move up with the PEEP as much as I can, but every new PEEP, I recalculate that plateau pressure and see where I'm at. But my default is 5, and I go up depending on their oxygenation need and if my plateau pressure allows me. I do sometimes switch to kind of using driving pressure. It's just there isn't an algorithm on how to use driving pressure to manage these patients. So it just defaults to kind of an individualized therapy.
We used to previously use diuretics as well in the case patient with ARDS with different other diseases. In COVID-19, severe COVID-19, can we use diuretics as well if they have a MAP above 60-65?
if you feel like they're good, and there's going to be a capillary leak, there's always going to be a capillary leak. So we definitely use diuretics. Probably after the first 24 hours, we move from kind of keep them slightly positive with fluids to even to then ultimately just diuresing. Diuresing isn't just fluid shifts, it's an activation of the NKCC2 protein that just allows the ability for fluid shifts to happen more naturally in regards to the lungs, where there isn't an edema buildup. So yeah, I love Lasix. I use it also, I see this because I use it even in renal when patients on dialysis. If it can activate their kidney, I use a low dose just because of the furosemide's effect on the NKCC2 receptor of your pneumocyte 2 alveoli in your lungs. So yes, I would encourage diuretics.
Last question I will add. The people with COVID-19, they are being ventilated for longer period of time. I guess I have seen people ventilated for more 21 days, more than 21 days as well. So in this case, patient is still having fever for more than 10 days. I've seen the cases with COVID-19. Do we consider antifungal infections, the antifungals for fungal infections as well?
Yeah, so we're definitely seeing superimposed infections in our most severe cases.
They also getting dexamethasone along with.
Sorry.
Yeah, one more time.
So longer duration infection, and along with that, they are getting glucocorticoid and fever for more than 7 days, 10 days. And do we consider antifungals as well?
So again, case by case, Rishab, there isn't a kind of hard, fast rule. From my standpoint, if they start on dexamethasone, there's new clinical deterioration, I'm going to add antimicrobials to help cover these patients and treating for nosocomial infections. That will be my go-to. Like if you got stability for a couple of days and they suddenly went worse, I would reculture, take sputum cultures and so forth. Antifungal infections I've yet to see in COVID-19. Again, that could also just be regional conversations. And I always have a low you just got to know who the patient is and what their risk factors were to develop a potential mold or yeast infection on top of what they're struggling. So I have yet to turn to an antifungal unless I feel like there's a specific reason to consider it.
Thank you. Thank you very much.
We had a question from Dr. Victor Contoja from Sierra Leone. Let me see if I can unmute Dr. Victor. Otherwise, I think he also typed the question. So he said, how do you proceed with the management of patients whose radiographic findings are very highly suggestive of COVID-19, but their PCRs are negative, despite full clinical picture of the virus?
Oh, I just treat them as if they have COVID-19. I'll be blunt. Like we have been told many times, and I'll never forget my first patient in early April. PCRs negative twice. We bronched them. Their lungs swimming with COVID-19. I would say if you have a high suspicion of this infection, treat them as if they have it. If you can get a tracheal aspirate or if you can do a safe bronch, do it just to kind of rule it out. But I would, I would treat as if it's COVID-19 until proven otherwise. You can start other antimicrobials. Maybe they have a superimposed bacterial infection, but treat as if they have COVID-19.
Right. Victor, does that answer your question?
Yeah, thank you very much, because it has been a dilemma most times in our facility wherein because the major challenge there is with respect to preventing the transmission from the patient you've first of all suspected has the virus, because in our facility we have an isolation center where every patient who is suspected to be COVID is kept. So once their PCR comes out negative, the relative want you to shift them to other facilities or to other places where the non-COVID patients are. So it has a whole lot of challenge even at family or relatives level. So that's why even at management level. So I just thought that it would be a good clinical question to pose these to other colleagues if they have similar challenges. Thank you.
Employees the week of Thanksgiving.
So let's see, there's one more question, and that is from Dr. Jose Alvarado. I think he's one of the, Dr. Alvarado, if you can ask it directly, or I can ask you from the chat box. What is the use of antihistamines in ICU, or does it depend on the clinical features of the patient with the presence of specific symptoms or signs?
Yeah, no, again, from an antihistamine standpoint, I would just say it's just individualizing it to the patient. If there's a reason to use them, um, that's go for it. You know, if they have certain levels of, you know, certain phenotypes of asthma who actually improve with certain levels of antihistamines, I would approach it. That's reasonable, but you just got to know the patient. You know, I say this because anything that kind of deviates from these guidelines, it falls on individualizing the care for that patient. I mean, I can't stress that enough. It's got to be, do you know this patient? So
Right, right.
that's what I would say.
Okay, and there's another question from, sorry, I think we're running a little bit over time, so I'll make it really fast. There's a question from Dr. Sanchez. How's it going, or what is your mortality rate in ventilator users with these recommendations?
So our mortality rate with regards to ventilation is probably about 15%. It's come down significantly over the spring. It was probably closer to 25 to 30%. I mean, it's high.
Yeah.
And I would say, you know, if your patients are on mechanical ventilations, I mean, that's your last resort of life support. So, you know, these are patients that, you know, oftentimes are dying with the ventilator, not from the ventilator. The reasons why we suspect it's come down, dexamethasone, and realizing like, all right, let's not be haste. You know, if they are ill, like, you know, we need to kind of, well, three reasons. One, we've learned to care for them a little bit better. Two, the introduction of dexamethasone. And three, a shift in the population that we saw. Early on, nursing home residents, very old, frail, lots of comorbidities. Now we're seeing just a lot more younger patients come into play. So that's probably what's changed. So if you need a ventilator, go for it. But I can tell you it's, you know, the disease has really progressed at that moment.
Right. So any other questions from Nepal? Dr. Kafle, Dr. Yadav, Deepak Yadav?
Hello.
Yes. Yes.
Thank you for this presentation. We are glad to have it. Just I want to know, is there any difference in the reinfection among the mild, moderate, and severe COVID?
So again, from a reinfection standpoint, I can only draw back to that 4 cases that's been published where those patients went through gold standard laboratory testing. They were young. I think the youngest was 18, the oldest is in the early 50s. They were all over the world, from Hong Kong to Ecuador to Nevada in the United States to Belgium. All 4 had mild cases, and then when reinfections, 2 of the 4 had moderate to severe. The one in Nevada was in the intensive care unit. So, you know, those were the gold standards that were done in order to kind of validate without any concern for doubt. And I think that raises a conversation that mild cases of coronaviruses may be analogous to other biological coronaviruses that we have, where you'll get some immunity for about 3 months, but it goes away, right? We know this with other coronaviruses. You know, this is why we usually get the common cold over and over again. So it would be a massive reason to continue drawing emphasis on public health interventions, because that's the way that this is going to go away. And it did with SARS-CoV and MERS-CoV long before a vaccine came out.
Right.
Thank you.
Thanks. And, all right, so I think we should wind this down. Any other questions? All right, I think this was excellent. And, you know, Panagis, I really want to thank you for doing such an excellent job with this wonderful and informative presentation, and also answering the questions well. And as you know, this was a special request from our Nepal chapter. And as you can see, there's a lot of interest in this topic. So thank you so much again. And I'm really grateful to you for doing this. And
an honor, and please share my contact information for others. You guys can have full access. We have also launched a COVID-19 public health intervention with schools, and we've been in from California to Sudan and Tanzania. So if you're interested to learn about this, happy to. There's research out of it as well. So let us know. Just please go ahead and share my. I'll even, you know, I'll drop my email address in the chat box. I'm all here to help you guys. We're colleagues.
Perfect. Thank you so much. And I will also share the email with everyone so that, you know, if you guys want to reach out directly, that's perfect too. All right, guys. Thanks for joining, and everyone have a wonderful and safe day, and we'll be in touch. Take care.